Good morning, everyone. This is Mark Erkin, and welcome to Thyroid Multidisciplinary Seminars. It is really a pleasure to introduce our two speakers this morning. Starting us off is Dr. Jennifer Brooks, who is currently a member of the faculty at the University of Rochester Medical Center. She is uniquely trained in both thyroid, parathyroid surgery, as well as pediatric otolaryngology. She comes at thyroid from a slightly different focus here. Her clinical focus is in thyroid and parathyroid surgery, both in children and adults. Dr. Dana Hartl is a full-time head neck surgeon and chief of the thyroid surgery unit at Gustave Roussy in Paris. She is joining us here from Europe and has presented many times on thyroid. Her expertise in thyroid, head neck cancer, and laryngology makes her uniquely qualified to discuss this morning's paper regarding recurrent laryngeal nerve invasion. She is the principal investigator on a prospective clinical trial evaluating the role of prophylactic neck dissection in thyroid cancer surgery, and she is widely recognized for her expertise in the field of advanced thyroid surgery. And so, as always, I'm going to encourage our participants who are listening to send in their questions. I think we will be flooded with discussion here this morning, but encourage you to send those questions in, and I will do my best to get to them before the end of the hour. So thank you all for joining us. And Jennifer, why don't you share your screen and get us started here?
All right. Well, thank you very much for having me today. My name is Jennifer Brooks. Thank you for the introduction. I'll be discussing our publication, Recurrent Laryngeal Nerve Invasion by Thyroid Cancer, Laryngeal Function and Survival Outcomes. This is a publication on behalf of the R-SCORE Research Group, which is a collaboration of excellent providers and researchers with our senior author, Dr. Randolph, geared toward investigating patients with laryngeal nerve invasion in the setting of thyroid cancer. So thank you again for having me. I have no disclosures for this presentation. So as we know, recurrent laryngeal nerve invasion occurs in a significant proportion of locally invasive thyroid carcinoma. RLN invasion represents an advanced disease process with the potential for significant patient morbidity related to possible vocal cord dysfunction. So issues, of course, with phonation, swallowing, and potentially airway compromise in the setting of a bilateral nerve invasion and vocal cord problem. As such, surgical management of the invaded RLN confers unique challenges to treating surgeons with vital operative planning and decision-making with regards to nerve resection and its possible consequences. Approach to the invaded RLN may be nuanced in part due to shifting recommendations over time. The American Head and Neck Society consensus statements from 2014 to 2018, for example, have evolved in terms of recommendation as to intraoperative management of the invaded RLN, with the most recent consensus supporting sacrifice of a grossly infiltrated or encased nerve and preservation of a superficially invaded nerve, or in the presence of a functioning vocal cord as demonstrated on preoperative exam. This is a schematic from the 2018 International Neuromonitoring Study Group Guidelines, essentially depicting how multifaceted this surgical management can be, and considering preoperative exam, degree of invasion seen intraoperatively, which we'll discuss more, intraoperative nerve signal finding, as well as discussion and patient preference. So the aim of our study is to enhance our understanding of the natural course of RLN invasion in the setting of advanced thyroid carcinoma, as well as the propensity for vocal cord paralysis and related morbidity in the setting, all to allow for improved surgical planning and augmented informed discussion around surgery with our patients. This is a retrospective study with patients with documented RLN invasion by thyroid carcinomas, nodal metastases, or both, who were operated on by senior author GWR from 1995 to 2015. RLN invasion was determined intraoperatively by gross inspection and confirmed histologically in patients when available after RLN resection. Multiple perioperative parameters were analyzed in association with 5-year recurrence-free survival, 5-year overall survival, as well as vocal cord paralysis outcomes. In total, there were 65 patients included with 66 nerves at risk. So one patient had a bilateral nerve invasion. 63% of the study cohort were female, with a mean age of 55.7 years and mean follow-up of over 5 years from treatment. The largest proportion of patients had, not surprisingly, papillary thyroid carcinomas, their tumor subtype, with smaller proportions of follicular, medullary, and undifferentiated thyroid cancer. And the source of invasion was found to be attributed to primary tumor invasion in about 60% of patients, and due to nodal metastases in about 30%, with the remaining percent due to invasion from both sources. In terms of surgical management, total thyroidectomy was performed in 36.9% of patients, and hemithyroidectomy or completion surgery in 43%. The high percentage of hemithyroidectomy and completion patients here is explained by subsets of patients either referred from outside institutions who needed completion surgery and treatment, a small subset with purposeful stage procedures, a plan for completion, and also some patients who had ablation, radioactive iodine ablation of contralateral lobes in the setting of a resected nerve and vocal cord paralysis. And this would be in collaboration with the endocrinology team. And all of these, of course, are evidence-based approaches for management of this condition. The RLN was resected in 48% of patients and preserved in 48 patients, which was 73%, and preserved in 17 patients. So approximately 3/4 of patients had nerve resection, which again was based on careful surgeon discretion upon preoperative factors as discussed, intraoperative nerve signal, and identification of presence and extent of invasion seen intraoperatively, which I will discuss on the next slide a little bit more. It's also important, I think, to note here to clarify this parameter of when tumor was left on the nerve or not, which was deemed to be an important additional classification, especially with regards to the analysis of adjuvant treatments. And I'll talk about that more in a little bit. So the decision to resect or not resect an invaded RLN depends partly on the extent of invasion identified intraoperatively, as has been described in prior studies, including, again, this 2018 International Neuromonitoring Study Group guideline on recurrent laryngeal nerve invasion. There are 2 categories of neural invasion as applied to the RLN and thyroid carcinoma. Whoops. Wrong way. Type A invasion is essentially perineural invasion involving usually only the epineurium, where the tumor may be fixed to the nerve, but can be shaved off the nerve with a macroscopically complete resection, as best as we can tell. The nerve trunk morphology, color, and caliber are typically normal in these cases, whereas type B RLN invasion, it extends beyond the epidural layer into the perineurium and endoneurium, and this is more where tumor is infiltrating and dissecting into the nerve. And so dissection and preservation of the nerve without leaving a macroscopic remnant is rarely possible in these cases. And these are found to have nerves with abnormal morphology. They may appear dilated, they may appear ecchymotic. So it's important to understand this distinction in terms of how these tumors were managed in our cohort, and also sort of thinking about how these are managed in general. After a mean follow-up of 65.8 months, 20 patients had local regional recurrence and 19 had distant metastases. And just as a reminder, of course, these were all patients at baseline with nerve invasion and more advanced disease. So this is really sort of the crux of the study, these results in our table 6 here. And it's important to note here as we discuss survival and recurrence-free survival outcomes, these are limited to the patients with papillary and follicular thyroid carcinoma, so our differentiated thyroid cohort. And we looked via multivariate analysis at various demographic and management factors, including age, gender, whether or not tumor was left on the nerve, like I discussed, post-operative treatment, including radiation therapy. And then what we found here, interestingly, was that the only significant factor was the use of radioactive iodine. So it was the only use of RAI was the only statistically significant parameter associated with improved 5-year recurrent-free survival and 5-year overall survival. And both of these parameters, we found significance. And then importantly, status of resection of the invaded nerve. So whether or not an RLN was resected in our cohort was not found to be associated with any statistically significant improvement in 5-year recurrent-free survival or overall survival. And we'll talk a little more about this, but points to potentially less prognostic importance of whether or not a nerve is resected in surgery. In terms of voice outcomes, only 24% of patients had preoperative voice complaints, and 27 or 43% had documented preoperative vocal cord paralysis via flexible laryngoscopy. And remember, these are all invaded nerve patients. And so we'll, again, discuss this more, but again, bolstering our current recommendations of how important it is to have preoperative fiber optic exam to assess vocal cords, even in the absence of voice complaints. So this is one of the largest single center studies of nerve monitored surgery devoted exclusively to invaded RLNs by a primary thyroid tumor or its nodal metastases. We found that resecting an invaded recurrent laryngeal nerve did not offer any statistically significant benefit on 5-year recurrence-free survival or 5-year overall survival. And we found that complete tumor resection, so whether or not tumor was deemed to be completely resected off the nerve, was also not associated with a statistically significant benefit in these parameters. And that radioactive iodine was the only statistically significant factor associated with improvement in both 5-year recurrent-free survival, 5-year overall survival, and this was regardless of the status of resection of the nerve or whether tumor was left on the nerve. And so this is, we felt, very important data in terms of the suggesting sort of the prognostic value, or in this case, potentially downgrading the prognostic value of whether or not a recurrent nerve was resected during surgery. And then in terms of voice outcomes, the findings here essentially support and are consistent with prior recommendations, including our American Head and Neck Society guidelines, which recommend pre-op laryngoscopy for all patients with differentiated thyroid cancer, and just reiterating that even patients without voice complaints, such as the significant proportion here, may have invaded nerves intraoperatively. And so understanding this is really important, both in terms of emphasizing the importance of these preoperative exams and also to help guide discussion with patients with potential for nerve invasion. So in terms of future considerations and how we feel our data may impact treatment options. So given the lack of a significant association between recurrence-free survival and overall survival with RLN resection status, or whether or not a tumor remnant was left on the nerve, it, as I've said, may suggest less prognostic significance certainly of resection of the nerve, and also may suggest less prognostic significance of RLN invasion itself in the setting of differentiated thyroid cancer. Essentially, it didn't matter whether a nerve was resected or not, whether a tumor invading the nerve was completely resected in terms of recurrence and survival outcomes here. And of course, while future study, which actually is in progress, comparing the same cohort of patients to those without RLN invasion to have a sort of truer control group may bolster this discussion around survival data and staging. Our results suggest that an invaded RLN really has less prognostic prowess than maybe it's historically been ascribed. And our consideration here is that, and this has been noted previously, is that perhaps RLN invasion may be considered more akin to strap muscle invasion in the current T3B classification in our current staging system, as opposed to T4A category with visceral invasion like esophageal or tracheal invasion. And essentially downgrading the importance of RLN invasion may also in turn downgrade the true staging of disease if it's staging at some point is reconsidered based on this and other findings which support these results. We do feel that based on our study results, we don't think RLN resection is necessarily mandatory in the setting of invasion. We do emphasize the importance of radioactive iodine treatment, of course, was found to be statistically significant here in these patients. Bolsters our recommendations, again, for preoperative laryngoscopy. And then at the end of the day, of course, surgeon judgment in terms of, having discussions with patients, evaluating what these tumors are doing intraoperatively and making decisions on whether to resect the nerve or not are still key and will be certainly can be individualized to a particular patient or case. With any study, we have our limitations. The retrospective design is one. We also noted possible referral bias with a sort of bigger care center where the study patient population was gathered, with possible variable treatment prior to transfer to our center, and then if patients went back to their home centers for post-surgical treatment as well. And then certainly it's difficult to quantify the amount of tumor that was left on the nerve. It's really unclear how variations here may have influenced outcomes. This is a large number of patients given the rarity of condition, and again, a bigger study looking at just invaded RLN nerve or recurrent laryngeal nerves. However, more robustly powered studies, certainly with longer follow-up, as well as those, as I mentioned, comparing patients without RLN invasion may better support our recommendations for possible staging reconsiderations. In summary, RLN invasion by thyroid carcinoma poses special challenges and considerations for treating providers. Neither RLN resection nor complete tumor resection off an invaded nerve were found here to be associated with change in recurrence-free survival or overall survival, whereas radioactive iodine was associated with improved survival metrics in the setting of RLN invasion and should be considered in the postoperative setting for appropriate patients. Laryngoscopy, to really bring this point home, remains a critical component of the preoperative evaluation in thyroid cancer patients, especially those with suspected advanced disease or nerve invasion, and even in the absence of voice complaints. And just in a final note that providers ought to remain vigilant about outcomes related to RLN invasion and surgical management and relay appropriate risks and benefits in consent and decision-making with our patients to optimize outcomes. Thank you very much for your attention. And I really look forward to the further discussions.
Okay, I guess I'm going to go. Dr. Brooks, thank you. That was incredible. Just beautifully explained a very difficult kind of a difficult data to tweeze. And so I'm actually probably going to repeat a lot of what you're saying and agree with you. Anyway, I want to thank the Thank Foundation again for the opportunity to have these exchanges and learn so much. I have no relevant disclosures, and just again, congratulations and thank you, Dr. Brooks. As Dr. Brooks said, there are several guidelines regarding locally invasive cancer and management of invaded recurrent nerves. And again, as Dr. Brooks said, in this study, it was a question of only the recurrent laryngeal nerve invasion type B, where the nerves were really encased and there wasn't really a choice about shaving. It was either leaving tumor or resecting the nerve. So what we call nerve encasement is this type B, where you see, as Dr. Brooks said, this abnormal nerve that's sort of swollen up with this tumor and these abnormal vessels. The guidelines, just to sort of resume what the guidelines say, because often, and that's, I think, one of the goals of the group that Dr. Brooks mentioned and is part of, is to just try to maybe predict nerve invasion preoperatively. We really don't know. And so often it's sort of discovered while we're in the OR. So we really have to remember to make sure that this is cancer and not lymphoma or just fibrosis before starting to wonder if we're going to resect the nerve or not. And then again, as Dr. Brooks said, it's very important to do preoperative laryngoscopy because a paralyzed vocal fold, generally in the guidelines, they say that we can resect the nerve, but then again, with the neuromonitoring, sometimes we're going to have some residual reinnervation, and we might want to be wondering if we shouldn't preserve that nerve. If the larynx is normal, then we wonder, can we preserve the nerve with shaving? Type A, or do we have something that's a type B and that needs to be resected, or type B that's going to be resected, or are we going to leave a remnant? And then we sort of fall off the slide here because there aren't any more guidelines after this. You know, what do you do with these encased nerves? So the guidelines help us up to this point, and then we're sort of stuck. I think it's very important to notice that in this study, these were very high-risk patients, whether it's for recurrence or death, according to the ATA, with the gross extrathyroidal extension and then some incomplete surgery. And then the T4A classifies these patients at a high risk of death. And then also the age, almost 2/3 of these patients were over 55 years of age. So it's not surprising that there were over 1/3 of the patients who recurred or had distant metastases. I think there are two things I kind of want to talk about from an oncologic standpoint that are really fascinating in this study, is that nerve resection did not significantly affect 5-year recurrence-free or overall survival, and that radioactive iodine did improve survival. And it's actually, you have to sort of read the sentence, it's survival was better in the patients who received radioactive iodine. And I'm going to go into that a little bit. As you see, this is taken from the publication. So first of all, other studies have shown similar results, that whether you preserve the nerve or resect it, survival is not going to change much. And in this slide, it's the limit of being significant, whether you resect it or preserve the nerve. And this is just sort of keep in mind that these are pretty rare cancers. If you look at some older publications, they're less than 5% of the total number of cases that we're going to be seeing. And these are heterogeneous groups of patients. We have recurrent nerve invasion, of course, strapmobile, but a lot of these recurrent nerve invasions are going to be associated with tracheal invasion, esophageal invasion, or other structures. So heterogeneous. We haven't got a lot of high-level data, and so Dr. Brooks's study was really also important because of the large number of patients. And so if you look at this literature, they also say, they imply that recurrent nerve invasion is probably not as bad as tracheal or esophageal invasion. And then there are other risk factors such as age, tumor size, and incomplete resection in non-recurrent nerve sites. And I'm just going to take one of these studies that I really appreciate and really want to recognize our colleagues in Japan, particularly Dr. Sugitani for this. They took a very large number of patients, and then they have over 200 patients who had locally invasive disease. So the first group was X0, no extrathyroid invasion. The second group had only strap muscular invasion. But what was really interesting in the study is that they had X2. They divided them up into patients where you could shave the nerve off the nerve. You could shave the tumor off the nerve or off the trachea or the esophagus. And then X3 was a group where you couldn't shave off the structures. You couldn't shave it off the nerve, and or the nerve was paralyzed preoperatively. And if you compare X2 and X3, they saw a significant difference in terms of recurrence at the resection site, which would seem sort of logical, that we get some local control when you can shave these tumors off. But then they showed that between X2 and X3, the ones you can shave and the ones you can't, that actually distant metastases and disease-specific survival were not different. So these patients, these locally invasive cancers are at some point, many of them are going to have distant metastases, and patients will die from their distant metastases. But they looked even harder and tweezed out a little bit more information from this data, and they divided these groups into the X-true group, where patients only had a recurrent nerve that was involved but that could be shaved, And then they had 13 patients who had involvement of the trachea or the esophagus or other sites. And the X3 was the same. They had only recurrent nerve encasement. They couldn't shave it, but they could resect it. And then 29 patients who had recurrent nerve involvement and deep involvement of the trachea, esophagus, larynx. And so if they compared only recurrent nerve and then other sites that could be shaved, actually only recurrent nerve shaving was better. Patients did better than in terms of disease-free survival than the patients where you had to shave the tumor off the other structures. And the same thing was for the X3. Patients who had only the nerve involved that couldn't be shaved but could be resected did better than patients who had deep involvement of other structures. So actually what happened, and then they looked at shaving the esophagus and the trachea versus an encased nerve, and there was no difference between those. So there's sort of three groups almost when you look at this data. Is there a group where you can shave the recurrent nerve that do well, and then there's this in-between group where you can shave the trachea or you can resect an encased nerve. And then you've got this third group of patients that do poorly because they have deep invasion of the visceral axis. I think it's really fascinating to see how the recurrent nerve, the kind of recurrent nerve invasion is not as bad as other T4 lesions. So evidence, again, low-level evidence, retrospective studies, but shows that it doesn't modify outcomes, and that the additional esophageal tracheal invasion is probably worse than an isolated encased nerve. So you could suggest it being down to T3B, or maybe just make a new classification, T3C, instead of T4. The question is, do we need more studies? Could we interrogate big databases, maybe with some algorithms to get a little bit more data on that, or is that enough to convince us? I don't know yet. The other consideration was that in this study was that radioactive iodine, the group of patients who had radioactive iodine had better 5-year overall and recurrence-free survival. And then if you look at the data, 32% of these patients did not have radioactive iodine, but then these patients actually, when they had the differentiated thyroid cancer, they had external beam radiation therapy instead. And there was some revision surgery. And we don't know if these were known to be radioactive iodine refractory initially or not. And then, as Dr. Brooks said, they eliminated from the study these other pathologies that were not going to receive radioactive iodine at all. But so when you look at how radioactive iodine is effective, it's actually most effective in younger patients. This is a study on distant metastases, but I think it goes for residual tumor in the neck as well, as patients who are young who have small residual tumor do better than patients who are older and have, of course, larger tumors. But then you've got you've got patients who are refractory from the onset, and we know often that PET positive tumors and aggressive pathological subtypes are often radioactive iodine refractory. So an aggressive histology, of course, is a factor for deep invasion within the nerve sheath. Is something that several studies have showed recently. It's also associated, again, with these radioactive iodine refractory lesions and with worse outcomes. So this is going back to this. I think the question is was radioactive iodine, was it sort of a confounding factor to say, well, look, patients did better because they received radioactive iodine, but actually these were patients that had the well-differentiated papillary thyroid carcinoma and not these unfavorable radioactive iodine refractory ones. And then was maybe external beam radiation therapy also administered to these patients who also had maybe deep invasion of the esophagus and the trachea, where we're leaving more tumor than we were comfortable with without doing the external beam radiation therapy. So maybe a confounding factor. And actually it comes to really that I think we have two different kinds of patients in these groups, in these studies, that are biologically different. We have a group of young patients with papillary or even the diffuse sclerosing variant in young patients that are going to be radioactive iodine avid, that have few or small, microscopic distant metastases. And so we know these patients are going to do well. And from the TNM, patients that are less than 55, even with metastases do well in terms of survival. So these patients are probably going to do well, even if we leave R2 on the nerve. However, on the other side, you've got older patients who more often have aggressive forms, or the poorly differentiated lesions. They're often not radioactive iodine avid from onset, and PET positive, or we're facing recurrent disease that we know to be a radioactive iodine refractory. These patients do poorly, and it's really sort of depressing for me as a surgeon to say this, but whatever kind of heroic surgery I'm going to be doing in the neck, these patients are probably going to recur, or at least recur with distant metastases, and do poorly anyway. So what's happening is that tumor biology is really determining the outcome here, which is why we should resect the nerve. You don't resect the nerve. It's the tumor that's going to decide, and it's not the surgeon. So I want to maybe be a little bit provocative here, and because we're seeing more and more systemic therapy, and I know there are a few prospective trials on neoadjuvant therapy. I wouldn't say we do it just to spare recurrent nerves, but you can see how we can get some really exciting tumor responses in these locally invasive cancers. And as we've all been seeing this revolution in anaplastic thyroid cancer, where patients become surgical candidates, the tumor becomes operable. I think we're revving up for a paradigm shift in differentiated thyroid cancer that's locally invasive. And I think we're going to be maybe rethinking our whole treatment sequence in the near future. Just a reminder, we have multi-kinase inhibitors. For now, they're approved for locally recurrent or metastatic disease, but I'm convinced in the future that they will be approved for these locally invasive lesions that are inoperable. And we also have, of course, the more specific kinase inhibitors, and then the BRAF and the MEK inhibitors that I hope very soon will have their indications also extended to these locally invasive lesions. Again, this is just an example of a poorly differentiated carcinoma. I just want to recognize my colleague in Bordeaux, Dr. Godbert. Just some great cases here. This was poorly differentiated, unresectable, and then you see this tumor that just sort of pulls itself away from the visceral structures. And then this was under just a multi-kinase inhibitor. And this was one of our patients who had this locally invasive disease. He also had some distant metastases, and so he was on lenvatinib because it didn't have any other targetable lesions. And you see how this is invading here, and the cricothyroid membrane is invaded, and there's actual tumor and embolism here, and then how this tumor just pulled away. And he had some toxicity from lenvatinib, and so we said, well, what do we do now? Well, let's just go do the old-fashioned way again. And what was really fascinating in this case is that the tumor had seemed to have shrunk away from the visceral axis and the recurrent nerve, and the nerve was actually just fine post-operative. It was pretty impressive. So are we going to be going toward a paradigm shift? I hope so. We'll see in terms of function. I'm sure it'll help some patients. Will it improve survival outcomes? I don't know, but maybe we could be starting to rethink our upfront treatment of these kinds of tumors. In any case, the resection of the encased nerve does not seem to modify outcomes. So for those of you who are listening, don't feel bad if you resect it. Don't feel bad if you don't resect it. And it also seems like isolated nerve invasion has a better outcome than tumors that invade the other visceral structures. And so are we revving up for reclassification of those? But I think really the main message is that tumor biology really plays the most important role in the outcome of these patients. And hopefully in the future, we'll be predicting radioactive iodine refractoriness preoperatively, and maybe do other things for these patients instead of trying to do all these extensive surgeries. Maybe not for nothing, but maybe we can do better. In any case, looking forward to the future with all these new things that are happening in thyroid cancer. And I thank you for your attention and recognize our whole team at Good to Oversee.
Terrific. Well, thank you, Jennifer, and thank you, Dana, as always, for a really outstanding discussion here. Jennifer, do you have any comments in response to Dr. Hartl's discussion, or I have a few of my own, but want to give you a chance to respond here.
Yeah, that was incredible, Dr. Hartl, too, and thank you so much for that discussion. I think that the discussion about the sort of biology and the sort of predetermination of outcomes is really fascinating, and I think that your kind of point there about whether you take it or not, either way, you know, not feeling bad about it, and kind of just de-emphasizing the importance of that resection or not is sort of our most significant contribution or thought there. And so, and then also, you know, discussing a little bit more, I didn't really get into it, but obviously the further study where you can better stratify based on aggressiveness of tumor subtype, even within papillary thyroid cancers, right? And so not just the overall subtype, I think will be important and provide more information here. But that was a really interesting discussion. Thank you so much.
Okay. Thank you. It's a very interesting paper.
Definitely. So Jennifer, I have a couple of questions for you, and they sort of dovetail onto what Dr. Hartl mentioned here. One of my questions is, do you have any data to support whether there was actually uptake on the REI scan in those patients who had R2 resections and had residual gross disease there? Do you have any follow-up information on what those whole body scans look like?
I don't hear, but I think the comment about, the comment about the effectiveness of radioactive iodine is well received in my mind, because certainly, you know, there are going to be certain tumors that are that respond to it or not. And so that may not be sort of revolutionary data, I guess, from our study, but and just not having sort of the granular data to understand who exactly responded and in what patients, if there was nerve left or not, just kind of limits us a little bit, I think, in interpreting it. But yeah.
And so the range of your follow-up was quite broad. It was anywhere from 20 months up to, if I read your paper correctly, up to 111 months. And my question is, of the 16 patients who had tumor left on the RLN, what was the follow-up in that subgroup of patients? Because that's really what the nitty-gritty of this discussion is about.
Yeah, in terms of the length of follow-up based on whether or not the tumor was resected.
Yeah.
I would have to look back at that. I mean, I think there was the mean follow-up is 5 years, and I'm not sure which patients off the top of my head particularly had the longer follow-up or not. I would have to look back into that, but I see your point there, obviously, and we kind of made a note that and have planned for further study looking at 10-year follow-up for patients. And so the longer term the data, obviously, the better we can comment on survival and recurrence. I think there was some limitation here because, as I mentioned, a lot of these patients were transferred for surgery and then went back to home institutions. And so we were a little bit limited just by that in terms of having all of the information for longer term follow-up. And so patients that may not have had that longer term data, it was likely related to that.
Yeah, I think when it comes down to it, the crux of the issue here really centers on that subgroup. They are to preserving that nerve and not knowing, right. I think there are a lot of things intraoperatively that we really don't know. We obviously don't know whether they are going to be RAI avid. Right. We don't know whether that portion of the tumor represents a more aggressive population of cancer cells here. And so one of the really important questions I have is, there were 20 patients with local regional recurrence, and how many of those recurred in the thyroid bed, and how many of those were in the subgroup of 16 patients who had tumor that you left on the nerve? Because that's really important here.
Yeah, whether or not recurrence was at the area where you left tumor on. I don't have a percentage, but I know it was sort of mixed group, and it was not a predominance of recurrence, you know, in the thyroid bed, mostly like central neck and lymph node metastasis, as opposed to a nerve related remnant that recurred.
Okay. Yeah. So, I mean, and again, it's, you know, I always worry about the residual tumor that's there, whether if that starts to behave badly, then you're in for an even rougher ride down the road here. And so I think, you know, all of these are thoughts that are running through your head as you're trying to make a real-time decision. And you want to, you know, your temptation is to do less, but there's so much uncertainty that you have in terms of the real-time data to know, is this the right thing to do? And this, and as a surgeon, your instincts are, you know, I should take this out because I don't have a crystal ball that's sitting right there at the time and say the cell is going to be what, not only is this going to respond to RAI, but what is this going to look like in the future? And these are often in such precarious positions, kind of right at the cricothyroid joint. And then you're looking at a more difficult scenario down the road here. So yeah, and I think Dr. Hartl brought up a really important point, and it's rare, although sometimes it is, you're often left with these mixed situations where you've got disease not only involving the nerve, but it's on the esophagus, it's on the trachea, or even at the joint. And so I wonder if the downgrading just for the isolated nerve involvement represents you know, something that in the majority of patients you're going to be downgrading esophagus and tracheal involvement here. So let me ask Dr. Hartl, how do when you've got epineural involvement and it's a type A according to this classification scheme, does that patient get classified as a T4A in your institution?
Oh, that's a really good question. If I just shave it, if I'm really in clear margins on the nerve, that it's not something where I have to like sculpt the nerve, where I have to do what our Japanese colleagues say, the partial thickness resection. Okay, if the nerve is really intact and it's fine, it's just kind of a budding, it's not a T4A for me. It's if the nerve is just not, it's something you can really dissect it. If it's on there, but you can really dissect it. Let's see. But if it's shaving, because there's shaving and shaving too.
Yeah.
As you know, there's the shaving where you're still leaving some tumor on the nerve, and you know it. And then there's this shaving where you're just in the soft tissue, and you know it. You can see it with your loops, and you're pretty sure you're not leaving a lot of significant tumor. And even that, in these retrospective studies, we don't really know what their definition of shaving is. So if I think I've left some tumor on, if I've had to leave some tiny bit of tumor on the nerve sheath, and I would call that T4A, because it's our call really as surgeons to say this is involved, this is not involved. So if I'm thinking I'm leaving tumor on the nerve, it's going to, for me, a T4A. But if it's one of these that's sort of these papillary, it's usually the nice papillary thyroid cancer that comes off the nerve pretty cleanly. For me, that's not a T4A.
So
I don't know if I answered right.
Yeah, no, I guess, I mean, there are two parts to that, and I think it represents the nuance of how we interpret these, large studies looking at nerve involvement, because, not only is there difference in surgical technique and philosophy, but also difference in this really important nuance of epineural involvement, which I would say that our anatomist friends would say, yeah, that is part of the nerve. And if you're taking the epineurium off, and the pathologist is never going to see that, they will never be able to make that determination.
Yeah.
But you, as the surgeon, are saying that the epineurium had to be removed in order to separate the nerve from that, whether it's a node or the tumor itself. So, I think that really raises the challenge for us of interpreting retrospect these prior studies and say, gosh, can I really extrapolate from that information in light of these nuances here? How much for both of you? How much are you using intraoperative nerve monitoring as you're dissecting that nerve to make that decision? If you're dissecting the nerve and your signal goes out, how does that influence your final decision if you're right there making that decision, that determination?
Yeah, I mean, I think I didn't really delve into some of our nerve monitoring data here, but if there's a good, adequate signal initially, and then a loss of signal, and most of these were found to be segmental loss of signal in our study, which I didn't really discuss, but so the area of nerve invasion as opposed to sort of a global injury from stretch, that here, based on our results, shouldn't really, if you can find that plane and resect tumor off the nerve signal shouldn't necessarily be the sort of determining factor in whether you resect the nerve or not. And there are some studies actually showing some recovery of nerves that are very superficially invaded with tumor resected successfully off. So in my mind, I think if it's something that, as Dr. Hartl was discussing, can be shaved off with sort of satisfactory removal of tumor, even if the signal goes out, I would probably opt, and per this data, probably continue to opt to leave the nerve intact, versus if it's a clearly encased or invaded nerve and the signal's gone, then you're using that data to decide on resection. But I think it's just multiple factors kind of together. Intraop.
Dana, how about you?
Yeah. I completely agree. It really depends on, again, how much tumor you're going to leave. But yeah, I think I think if you can preserve the nerve, even if your signal goes out, a lot of these patients are going to recover. And so it's still a matter of, as in your publication, whether you resect or you're going to leave some tumor. I think there's also an interesting question about if you have vocal fold paralysis, but then you go in and your nerve is still stimulable and you still get a signal on that side. It might be a little bit, so it means that there's still some influx going. Is that even if you have vocal fold paralysis, is that in that kind of situation, should you maybe try to preserve the nerve, and would you? And that's also, I think the other way around is maybe more difficult than if you have loss of signal, but you can preserve the nerve, patients usually recover. But if you still have a nerve that's sort of functioning electrically, then maybe it's worth trying to shave it off in some patients to have that residual innervation. I don't have the answer.
Yeah.
So it works both ways.
Great. So just one question for you, for both of you. How do you communicate? And this is a little bit off topic, but circling back to the question of communicating your findings in the operating room to your pathologist. How is that done in each of your institutions? Because to get to an accurate post-surgical staging, that communication is vital. Do you leave it up to the pathologist to read your op note? Do you communicate right away, or do you, how is that actually done?
Dr. Hartl, I'll defer to you first.
So that's a tough question. It is a tough question. Usually, like if I'm resecting the nerve, I'll put like threads on the end or clips on the end, so that and I'll say, you know, let the pathologist, look, I've resected this nerve. You're gonna, you know, look at it and see if it's really invaded, but it doesn't change anything. But at least we've got the proof that the nerve was invaded, so that you don't have any, I guess, regrets. But no, usually. At the end of the operating report, I do a little summary, and I say the nerve invaded, the nerve was invaded, you know, was resected, the esophagus was invaded. We have gross, and I sort of do a little bit of list of the principal structures that have invaded and where I've left tumor. I'm sorry. And then sometimes I'll also put clips in, like where I've left tumor, if it's a patient who's going to have external beam radiation therapy, so that they can do some of the they can center the radiation on that. But that's a very tough question. It really is.
Great. I have two questions. One is coming to us from Paraguay, from Dr. Samudio, who asked, states that we have a large number of patients with advanced thyroid cancer. Why would you ask for a laryngoscopy in all patients, no matter RLN invasion or not? Or is this more for either statistical analysis or medical legal concerns here? Jennifer, do you want to comment?
Sure. So let's see, large number of patients. Why would you ask for language? I think I'm understanding the question. Yeah, I mean, I think our kind of point here, and this was consistent with prior study and even our sort of consensus statements now, is that in the setting of thyroid cancer, you may have patients who have nerve invasion, who have either or both normal preoperative voicing and normal preoperative laryngoscopy. And that was sort of our finding here. And so one part of it is, first of all, patients who have normal voice but are found to have a vocal cord paralysis preoperatively is certainly an important finding in terms of consent for patient and understanding of the risk of nerve invasion, which is, you know, a lot of this is just understanding before we get in there, trying to predict as much as we can before we get in there, is the nerve invaded or not, and what is the likely outcome for a patient. And so making sure that we don't miss that small subset. I think in some studies, it's upwards of like 30% though of patients who may have normal voice, but a paralyzed cord pre-op found on flexible laryngoscopy. And then the other part are the patients who may have nerve invasion who have normal preoperative laryngeal function. And that's a little less sort of clear and obvious of why it's important that we're looking for those patients to understand that preoperatively. But I do think that if we want to be able to, you know, really understand our rates of pre and postoperative paralysis, we have to be looking. And if we're, you know, unsure about the importance of resecting a nerve or not, and what that is going to do for vocal cord function, if we're preserving a nerve that may be invaded or not, then really understanding what the vocal cord function is like preoperatively, understanding intraoperatively, you know, what the signal is telling us, and then postoperatively what the long-term function is, I think is critical. We just can't really fully understand this unless we're looking. And so, you know, kind of two-tiered: one, just for better understanding, and two, not to miss the small subset of patients where there actually may be a problem that we won't see unless we're evaluating.
And yeah, thank you. And Jennifer, the follow-on question really sort of dovetails to that, and that is that if you have any information regarding those nerves,
Yeah.
how many of those were functional after, and how many were functional long-term?
Yeah, I mean, again, our data was long, I guess it depends how you define long-term. I mean, in our follow-up with an average of 5 years, that's the length of data we have so far. Of course, we'll look at this again with longer term data in the future. But there were a majority of patients who had preserved nerves that were functional preoperatively maintained function long term. There was a really small subset of patients, and I'm trying to record here, who had a vocal cord paralysis post-operatively that didn't in the setting of a preserved nerve. Obviously, if you resected a nerve and or did an anastomosis, you were going to have a post-operative vocal cord paralysis. But in terms of normal pre-op function and nerve preservation and surgery, a majority of patients maintain normal vocal cord function at least the length of our study follow-up.
Great. So, Dr. Hartl, if you alluded to this, but if you have information regarding specific mutations that are present before going into surgery, or if your cytologist raises concern about tall cell variants or any other of the more aggressive histology subtypes, how would that influence your intraoperative decisions if you're at the crossroads to resect or to preserve a nerve here?
Yeah, that's also a tough question, and it's the decisions you have to make in the OR. I actually, if I know that it's a tumor that's going to be radioactive iodine refractory, and if we're in there for cure, the patient doesn't have distant metastases, and we're trying to get this all out, or at least majority of it, maybe with some external beam radiation therapy, then I would probably be more aggressive with nerve resection, because, well, if we're trying to go in for cure. But I'm sort of contradicting myself, because we know that a lot of these patients then are going to have distant metastases later. But I guess the idea would be to try to optimize local regional control and maybe cure in these patients that we know are not going to be amenable to radioactive iodine later. And that goes for recurrences also, recurrences that we know are PET positive and are refractory. If we're really going in there surgically, then the aim is to get it all out, as we say, and to try to get R0, R1 resection, then I would be more aggressive. Maybe I'm wrong.
My last question, and we're up against the 9 o'clock hour. Does frozen section play any role in your intraoperative decision making here, either with respect to margins or trying to get a better handle on the type of tumor that you're working on? Obviously, if we keep this within the realm of differentiated thyroid cancer.
Yeah, I'll take that. It doesn't really for me too much. I'm not going to do really frozen. So I do it for tracheal resection, I think, but maybe not for the nerve. I really would just look at where I think the nerve looks normal if I'm going to be resecting it. And then when you get these abnormal vessels that start, I would resect it just visually. So no, for nerve resection, unless you're really not sure about the pathology, if you think it might be lymphoma, it might be something else, then of course you really need to, or you have this weird, something strange that's maybe, the cancer wasn't diagnosed before and you have this nerve that's invaded, then you're going to want to be doing it. But if you know it's a thyroid cancer, I'm not sure that they can actually do diagnosis of aggressive variants on frozen section.
Great. All right, listen, I truly appreciate this session, and great job for both of you. And thank you for all the work that went into to presenting here this morning. I hope we will see as many of you as possible in London coming up in June. And as always, we will be back again next Friday morning. And thank you all for joining us. Take care. Bye-bye.
Bye.